Hello everyone, thank you for the opportunity to present. My name is Mike Hartung from the University of Wisconsin, and I'm going to discuss CT of complex small bowel obstructions. As we journey into more complex or challenging cases in this talk, let's take a moment and appreciate the features of a more straightforward single point obstruction. And I think we can all agree that the small bowel feces sign is a wonderful gift when evaluating these sorts of cases. Small bowel fecalization saves us time in running the bowel and directs us to the transition point in many cases. To remind you, this sign refers to the contents of small bowel taking on the appearance of stool or feces containing little small black dots of air. Fecalization occurs here because the bowel contents have sat the longest, and over time the water content has become resorbed, causing it to take on the appearance of stool. The presence or absence of this sign helps us to assess some more complex cases and also serves as a helpful springboard for our talk. For many of these cases, we're going to have to dive in and get our hands dirty and look thoroughly at the entire GI tract to determine the cause of the pathology. I've roughly broken up the categories of complex bowel obstruction into mechanical, inflammatory, neoplastic, and closed-loop etiologies, and we'll start with some mechanical causes. This first case is presenting with multiple dilated loops of small bowel suggesting a small bowel obstruction. We're going to jump ahead to where the action is, and here in the right mid-abdomen is the transition point. At the transition point, there is an oval, dense structure which appears to be causing the obstruction. Where could such a structure come from? Let's take a closer look at the upper abdomen. Here along the lower liver margin, we have a decompressed gallbladder with a thickened wall and some surrounding stranding, and also some air in the lumen. And as we scroll back, we see a very clear cholecystoduodenal fistula or cholecystenteric fistula, where the gallbladder eroded and fistulized to the second portion of the duodenum to cause gallstone ileus, small bowel obstruction. It is important to recognize the varying appearance of the obstructive gallstone in cases of gallstone ileus. And while in our first case we benefited from a partially calcified wall, oftentimes the gallstone can blend in with the enteric contents, causing a diagnostic dilemma and delayed diagnoses. Other times you may see a lamellated appearance like this. So keep in mind that it may be isodense with the enteric contents, lamellated, or partially or completely calcified when potentially evaluating this cause of obstruction. Our next case of small bowel obstruction from mechanical cause has relatively decompressed small bowel loops proximally containing oral contrast, and as we scroll distally, we have slow dissolving of that oral contrast with the darker enteric contents until we reach the pelvis, where the enteric contents become much more fluid-like, indicating we're getting closer and closer to the point of obstruction. This appears to be the loop closest to the point of obstruction. So as we scroll back and forth and try and look for the cause, no clear cause is found. It might be tempting in a case like this to move on and attribute the obstruction to likely from adhesive disease, but it's important to scroll all the way in the pelvis and also look on multiple planes. And here, as we continue to scroll down deeper into the pelvis, we find that the patient has a hernia as resulting in the obstruction. This is a special type of hernia. The small bowel loop is confined between the obturator externus and pectineus muscle. Here's that transition on the coronal images. We can follow the distal dilated small bowel down into the hernia sac, and then right here back up into decompressed loops. So this is an obturator hernia. So you'll find a recurrent theme in this talk with many of these cases is that you have to run the bowel meticulously on multiple planes in order to determine the cause of obstruction. This next case is an important variation of a small bowel obstruction. This is in a patient with a history of gastric bypass surgery, and you'll notice here in the roux or alimentary limb in the upper abdomen, it is relatively decompressed and contains oral contrast. However, next to it is this dilated excluded stomach, here to the pylorus and duodenum, passing into the duodenal sweep, and finally as we scroll into the abdomen, we end up with multiple dilated loops, relatively dusky in appearance with mesenteric edema. This is certainly a confusing case, and I think the coronal images help quite a bit, so let's take a look. Here we get a better picture of what's going on here. The root or alimentary limb is decompressed. However, the afferent or hepatobiliary limb is dilated. The excluded stomach is dilated, and as we pass across midline, we reach the duodenal sweep, which is quite dilated, and here appears to fall into a defect within the mesentery, resulting in this large cluster of entrapped small bowel that is asymmetrically dilated with mesenteric edema. Here we have an internal hernia causing obstruction of the afferent limb through a mesenteric defect related to the patient's jejunostomy. This required urgent surgery and resection of multiple loops of small bowel. And so it's worth a pause to talk a little bit more about afferent limb obstruction. Afferent limb obstruction is obstruction of the hepatobiliary limb in a patient with gastric bypass anatomy. Oftentimes the treatment teams, when they hear obstruction or even afferent limb obstruction, will have some degree of confusion and may consider reaching for a nasogastric tube. But a nasogastric tube will not work and address the cause of obstruction in these patients. And so it can be particularly helpful to pick up the phone and talk with the team directly about the findings, and also report the afferent or hepatobiliary limb separately from the root or alimentary limb in your impression, so everybody's clear about what's going on in the case. It is often helpful for us in cases like this to draw out our understanding of the anatomy. Here we're talking about obstruction of the excluded stomach or the afferent limb, and it can occur upon multiple points prior to the jejunostomy, including related to adhesive disease, mechanical causes, internal hernia, or even cancer. So that wraps up our discussion of some mechanical causes of complex small bowel obstruction, including gallstone ileus, obturator hernia, with remembering that we're also looking at inguinal or femoral hernias and ventral hernias, and afferent loop obstruction due to a variety of causes, and in our particular case, internal hernia. We are now ready to discuss some inflammatory causes that can cause or simulate a small bowel obstruction. This first case, this patient presented with a several-day history of abdominal pain and came to the emergency department for imaging. There are several dilated loops of small bowel, but no clear transition point. However, in the right lower quadrant, we can see particularly thickened long segment loop of ileum. We could characterize this as mucosal hyperenhancement, submucosal edema, and also serosal hyperenhancement. This is called mural stratification and results in this target sign appearance. There is associated mesenteric edema and also some ascites. Several days earlier, the patient started a new medication. Can you guess what it is? Yes, it's an ACE inhibitor. This is ACE inhibitor-related angioedema. And what I found in my experience is don't count on the emergency department to tell you the medication history. It's really something that we have to think of, bring up, and ask in order to get right in most cases. This patient can be managed conservatively with changing or cessation of the medication and supportive care. This next case looks a lot like the last case, with similar imaging findings of long segment, small bowel inflammation, some dilated loops upstream, and that similar appearance of the target sign related to mural stratification. This patient also came to the emergency department and had a several-month history of waxing and waning abdominal pain and was largely a puzzle to the team to manage at the time. The patient turned out to have elevated peripheral eosinophil levels and eventually underwent a biopsy which confirmed eosinophilic gastroenteritis, which is often self-limiting and can be effectively managed with steroids. This next patient is presenting with multiple dilated loops of small bowel, and in the right lower quadrant, we find a long segment of thickened and irregular terminal ileum, and as we scan more closely, we see small areas of strandy soft tissue connecting that loop of ileum to other adjacent small bowel loops. Let's take a closer look on the axial, which I think helps define the anatomy. Scrolling backwards from the terminal ileum here into that thickened loop in the right lower quadrant, we find this backward C-shaped loop here with strandy communication between multiple small bowel loops indicating entero-enteric fistulae, and also some fistulous communication here with the sigmoid colon. This is related to Crohn's disease with multiple complex fistulas in the right lower quadrant, also causing a partial small bowel obstruction. This next case presents with dramatic increased thickening and inflammation of the entire gastrointestinal tract. It starts in the stomach, involves the entire small bowel, and also involves the colon. There are some other important findings that help us with this diagnosis. If you look carefully towards the bladder dome, you can see some areas of nodular thickening and enhancement. There is even thickening enhancement along the ureterovesicular junctions bilaterally here, which is resulting in mild bilateral hydroureteronephrosis. Here's what that looks like on the axial images. As we scroll down into the pelvis, you see nodular thickening along the bladder dome and the ureterovesicular junctions bilaterally. This indicates a systemic inflammatory process, and this patient had elevated inflammatory biomarkers and was eventually diagnosed with lupus vasculitis, which can also have genitourinary manifestations, such as the ones that we see in this case. This next patient is a young female presenting with small bowel obstruction. Here we find the oral contrast dissolving into dilated distal small bowel loops containing darker, more fluid-like contents, indicating that we're reaching and nearing the point of obstruction. But as we try to trace out the distal small bowel, it becomes quite difficult. We find these lobulated, thickened distal small bowel loops, which are intimately associated with the uterus and adnexa. But beyond that, it's difficult to make a diagnostic comment as to the cause of obstruction. This patient was managed conservatively with nasogastric decompression and sent home. The patient came back about 1 month later with recurrent symptoms. This time, the small bowel is not nearly as dilated, but as we go back to the pelvis, we find some chronic changes have evolved. There's fecalization within those dilated distal loops, which are in a similar configuration and association with the uterus and adnexa. The small bowel loops are thickened beyond the point of fecalization and have an irregular tethered appearance in the pelvis. In the operating room, they found numerous hemorrhagic deposits within the small bowel loops and peritoneum related to endometriosis, causing the recurrent small bowel obstructions and requiring the small bowel to be resected. It's helpful to consider this diagnosis in female patients, particularly when the cause of obstruction is not clear. You can see the degree of scarring and inflammation related to these deposits is quite extensive and initially relatively underestimated by our first CT. This next patient at first glance might look a lot like our ACE inhibitor-related angioedema or eosinophilic gastroenteritis patient. You see that same pattern of long segment small bowel wall thickening. You even get a little bit of target sign. However, the degree of enhancement is overall somewhat less, and this post-operative history is important in this patient. The patient had a total colectomy due to the diagnosis of ulcerative colitis and developed worsening abdominal pain after surgery. And as is often the case, it's hard to see what's not there. But in this case, there is no significant enhancement of the superior mesenteric vein because it is largely filled with clot, and that clot extends into the portal vein and intrahepatic branches, which helps us to make the diagnosis of superior mesenteric venous and portal venous thrombosis. This is venous ischemia, and a relatively typical look for it, where the bowel becomes thickened and there's mesenteric edema. The edema around the venous vasculature can also help you and prompt you to do a more careful evaluation for venous patency. In this case, it's also similarly difficult to see what's not there at first, given the extensive abnormal involvement of the small bowel. But this small bowel wall is too thin and it's not enhancing. We can make that observation more concretely when we compare it to some of these enhancing loops of proximal jejunum. If we look carefully at the arterial phase images here, we can follow the superior mesenteric artery down to where it thromboses, accounting for the acute arterial ischemia involving the majority of the small bowel. And so these last two cases give us the important reminder to carefully check the vasculature on every case for venous or arterial thrombosis as the cause of abnormal bowel thickening. It's also helpful to acknowledge that many of these diagnoses we discuss have overlapping imaging features. They all have thickened bowel walls. We see increased enhancement of the mucosa, submucosal edema, and serosal hyperenhancement, and we can also have some degree of ascites or mesenteric edema. The clinical context for these patients and the presentation and laboratory values will often help to inform and modulate our differential diagnosis. But in some cases, we may be left with providing the team with several of these ideas to help them sort things out further with additional laboratory, clinical, or endoscopic or surgical evaluation. Keep in mind that for patients with a history of cancer, there are some important diagnoses to consider. The first is that of a patient who has a history of radiation therapy. And this patient had cervical cancer and pelvic radiation with the typical marrow changes we associated with radiation therapy in the pelvis, helping us to inform our understanding of the radiation field, and some segmental thickening of distal small bowel resulting in a partial small bowel obstruction related to radiation enteritis. This second patient presented with several dilated and thickened loops of small bowel and had a history of lymphoma and bone marrow transplantation with biopsy-proven graft versus host disease, another important cause of abnormal bowel thickening and enhancement in patients with bone marrow transplant history. And so that covers the scope of several inflammatory disorders that can cause obstruction or obstruction-like conditions, including angioedema, eosinophilic gastroenteritis, vasculitis, endometriosis, Crohn's disease, and in the important mimics of venous and arterial ischemia. We're now ready to move on to some important neoplastic causes of small bowel obstruction. This first case presents with a partial small bowel obstruction or some overlapping features of enteritis, where there's some thickening of small bowel loops and also some dilation of them. The transition point is a little hard to find at first and is in the right lower quadrant, where there's some abnormal circumferential soft tissue thickening of the distal small bowel. It sticks out a bit more on the axial images, and I'll show you that here. We followed the distal small bowel into the circumferential soft tissue mass, causing a partial small bowel obstruction. This was resected and turned out to be a small bowel lymphoma. So it broke the old adage of lymphoma not typically obstructing, and indeed, lymphoma usually causes bulky, non-obstructive disease of the small bowel as it invades the myenteric plexus and causes it to cavitate. But of course, there are exceptions to that. Lymphoma can also cause solid organ manifestations and nodal disease. But don't be afraid to think outside the box and also expect some atypical presentations of lymphoma as well. This next case presents with a relatively high-grade small bowel obstruction with a transition point in the right lower quadrant here at this irregular ileocecal mass. There are also some mildly enlarged and slightly irregular-looking ileocolic lymph nodes. This is a relatively typical appearance of an ileocecal adenocarcinoma. And of course, don't forget a large bowel obstruction causing a small bowel obstruction secondarily as a result of reflux through the ileocecal valve. Here, if we follow the transverse colon across midline, we see a second finding of an intraluminal mass here that might be important and inform their surgical resection. And as we continue to scroll distally along the descending colon, we find mass-like shouldering and narrowing and multiple abnormal mesocolic lymph nodes. This is from colonic adenocarcinoma. This next case is a bit of a puzzler on the axial images. The patient has a history of herniorrhaphy and comes to the emergency department with abdominal pain. At first glance, you might think that there's some chronic inflammation or adhesive disease potentially related to the hernia repair. It's quite difficult to appreciate on the axial images at first glance that this is related to a neoplastic process. We find that the coronal images help quite a bit with review in this case. As we scroll back and forth on the right lower quadrant, trying to sort things out, we can find this spiculated mesenteric nodule with surrounding desmoplastic reaction corresponding to the transition point. This is a carcinoid tumor with typical spread to the mesentery resulting in desmoplastic reaction. This next case presented with abdominal distension and symptoms of obstruction. There's extensive fluid and intermediate attenuation material throughout the peritoneal cavity. In the right lower quadrant, there's this tubular structure containing flecks of calcification. In the upper abdomen, there are dilated loops of small bowel. In the transition point here in the right mid-abdomen, where there appears to be some invasion into the small bowel wall. This is pseudomyxoma peritonei, with invasion into the small bowel wall, resulting in a small bowel obstruction. This is due to rupture of an appendiceal mucinous neoplasm, which we can partially see here in the right lower quadrant. That concludes our review of some important neoplastic causes of complex small bowel obstruction, including lymphoma, adenocarcinoma, carcinoid tumor, metastases, and colonic adenocarcinoma. Let's wrap up the talk with one of my favorite topics, closed-loop small bowel obstructions. This augmented image illustrates the most common cause of closed-loop obstruction, that is, an adhesive band under which small bowel loops will slide, dilate, and become trapped. This causes the 2 points of obstruction, going in and coming out of that loop, which define the closed loop segment and isolate it from the remainder of the gastrointestinal tract. This puts this loop of small bowel at a risk for becoming ischemic as its secretions become trapped and it continues to dilate. It is helpful to think of closed loop obstruction as a spectrum that can involve a combination of adhesive disease, internal hernia, and volvulus. Internal hernias are congenital or surgical defects in the mesentery or omentum that can trap a segment of small bowel as it slides through that defect. Importantly, both adhesions and internal hernia can serve as a lead point for developing volvulus because the bowel on both the proximal and distal ends continues to peristalse, leading to twisting of that entrapped segment. I have also seen many surgeons describe adhesive bands causing internal hernia-like defects in their operative reports. And in some combinations, there's both a combination of adhesive disease and surgical mesenteric defects, particularly when there's a history of prior surgery. So don't get too caught up on the terminology and just focus on making the important diagnosis of the closed loop obstruction. In general, it is best not to expect cleanly demarcated categories of disease and to look for a spectrum of both clinical presentation and imaging findings when making this diagnosis. Our first case of closed-loop small bowel obstruction has oral contrast on board within relatively decompressed proximal small bowel loops. However, as we scroll into the lower abdomen, we see that oral contrast dissolving and also some loops of small bowel which do not contain oral contrast. This cluster of small bowel in the right abdomen appears to have asymmetric mesenteric edema here and also some surrounding fluid. Let's see if we can characterize this loop a little bit better. We'll follow this loop of small bowel across the midline and find our first point of obstruction, this beaking of the small bowel. We'll carefully follow the rest of the small bowel to see if we can find a second point of obstruction indicating a closed loop. And we're right about there. There it is, the second beaking. And you notice how they're right across from each other, indicating that there's an adhesive band between these bowel loops, causing a defect through which the small bowel slid and became entrapped, forming a closed loop. Also notice how in the coronal images, we can appreciate the asymmetric mesenteric edema and somewhat radial orientation of these small bowel loops. But the transition points are much harder to sort out. What you're going to find in these cases is that the transition point will be best seen on one of the three planes, so make sure you scan on axial, coronal, and sagittal when you're trying to characterize a closed loop obstruction. In the operating room, they found an adhesive band here and here, causing the closed loop obstruction. So we can draw that in, remembering that adhesive bands are not visible on CT and blend in with the fat, and thus we must infer their existence based on the impact on the small bowel. This next case is less of a mystery that there's significantly abnormal small bowel within the right abdomen. The upstream small bowel is quite dilated, making it a little bit difficult at first to evaluate the transition points, but skipping ahead here, we can follow this dilated loop across midline to the first transition point into this closed loop here, and we'll scan through and follow the rest of that small bowel out of the closed loop right here as it dives backwards into decompressed distal small bowel. The sagittal images help us to see the transition in and out of the closed loop best, where we even have that expected typical beaked appearance from the adhesive band causing the closed loop. This thickened small bowel loop might appear to be inflamed at first glance. However, we benefit in this case from non-contrast images. which show increased density of that small bowel loop before contrast was given. This is related to hemorrhage within that small bowel loop as a complication of ischemia. As a result, a long segment of small bowel had to be resected at the time of surgery. This case is particularly scary because it is so easy to overlook the closed loop on the axial images. There are several dilated loops of small bowel here, and as we follow them into the right abdomen, we easily miss the first transition point on axial images, which is right here, and scrolling through this loop here, really only see that second point of transition well, making it very tempting to cause this a simple small bowel obstruction related to adhesive disease. However, notice some asymmetric thickening of these loops of small bowel, which turned out to be quite significant at the time of surgery, as this small bowel was hemorrhagic and needed to be resected. The coronal images really save the day here, and we see that C-shaped loop of small bowel, which we should not typically see, or even a partial U-shape here, and we can follow the transition point of upstream dilated small bowel in here and out right here. Our last case of closed loop small bowel obstruction highlights an important variation that you should be aware of, and that is for gastric bypass patients. Scrolling through these axial images again is very challenging to identify the abnormality, and at first glance you might just pass this off as relatively normal study or perhaps some gastroenteritis in the right mid-abdomen. But there is some asymmetric edema. One of the important things to do in cases of gastric bypass patients as they're at increased risk of internal hernia is to carefully follow the venous vasculature. Here, as we follow the superior mesenteric vein, we find that it does some strange curving and angulation here. It'll be important for us to sort that out on the coronal images. As we scroll through the coronal images, at first glance we're seeing more of the same, but as we carefully look at that same area, things start to come into view on a few of the key images. Here we see a radial orientation of small bowel with asymmetric mesenteric edema, the vessels pointing towards a central point of convergence where they slid into an internal hernia defect. And as we carefully look at the mesenteric vasculature, we see superior mesenteric venous branches coming anteriorly and curving up at strange angles, indicating a non-physiologic, non-anatomic configuration of the bowel, often seen in the setting of internal hernia. Internal hernia was confirmed at the time of surgery related to a mesenteric defect from the jejunostomy. Let's bring it all together by talking about the key findings that we see with closed loop obstruction. First, there's this beak sign at the entrance and exit of the closed loop where there's sharp angulation and transition of the small bowel. There's asymmetric mesenteric edema involving the closed loop, a clustered appearance of the closed loop with radial orientation of the vessels, hemorrhage or hypoenhancement related to ischemia, a dilated U or C-shaped loop on the coronal images, and swirling or narrowing of the mesenteric vasculature. In summary, we have discussed several important causes of complex small bowel obstruction or obstruction-like conditions, including mechanical causes, inflammatory causes, neoplastic causes, and closed loop obstruction. On a final note, I learned so much from following up my challenging cases and carefully reading operative notes, and I really encourage you to do the same. Doing this will connect us to the clinical teams, the surgeons, and patients in profound ways, give us insight into our reporting, and help us to know how to communicate key findings in a clinically meaningful way. Thank you so much for your attention during this talk, and I hope you've learned something helpful for your practice. Many of the cases that I've reviewed are available at this QR code in a Radiopedia playlist, which you can scan with your smartphone. Thank you again.